Well, hey, welcome back to the Scale My Clinic podcast, and I'm really excited today. I've got my good buddy Sachin with me, but we also have Chris Smeed, who is CEO of Cubiko, all-round data nerd, ex-practice manager. Still a little bit of practice management, I think, going on there, Chris. But I'm going to hand over to Sachin, and we're just going to be chatting about today. Don't drop the ball during the pandemic. And I think it's not just one ball, it's probably, like 5, 6, maybe 7 balls that you need to keep in the air. So I'm going to hand over to Sachin, and he'll have a bit of a chat with Chris. Thanks.
Welcome to the podcast by Scale My Clinic, founded by Doctors Todd Cameron and Sachin Patel, who are on a mission to help every general practice owner achieve his or her dream. The Scale My Clinic podcast is designed to leave listeners with insights and understanding gained by real lived experience that will help general practice owners create impact, get their time back, and enjoy increased revenue. Join Todd and Sachin every week as they share their stories on the Scale My Clinic podcast.
Cheers, Todd. Morning, Chris. Welcome.
Morning.
I'd love to hear your thoughts here, because you have access to a lot of data, and data is one of your best friends.
It is sometimes my only friend, depending on the day of the week and how many red wines I've had.
Absolutely. And so the question really starts with: it's been a very hectic time so far over the whole pandemic period, and that's out of necessity, we've had to adapt and change. And currently, at the time of recording, there's high volumes of vaccination required through general practice. But the reality is that the normal business of general practice, the normal work that we have to do, hasn't gone away. So the vaccination work and the other pandemic preparatory work is in addition to the normal function of a general practice. And so it could be easy in this whole phase of change to have put all our attention and focus on just trying to keep up with all the change and the new things that are asked of us. And so I'm really keen to hear your thoughts about, 1, 2, or 3 areas that the clinics should be still remembering as their bread and butter, and how to keep their focus on those areas.
No, it's a great question. And we have a lot of chats about that here at Cubiko every day. Vaccines have been a huge, and I'm going to use the word distraction, because the core business of general practice didn't stop shop, and caring for patients didn't stop shop. And I'll tell you one quick story around that, because I think sometimes stories are good to mitigate that. And we were working with some clinics, and they got really, really, really involved in vaccine rollout. And the nurse who was leading that was also the nurse responsible for their recalls. And you know what started to slip? Recalls. And you know what started to slip most of all? Urgent recalls. And the greatest moment of patient care, of clinical risk a clinic takes as a clinic rather than the individual provider, and we're talking about clinic owners here, is actually in processing that recalls and reminders workflow. And you know what? It was like, oh, I'll get to it. And it wasn't being got to. And to me, that just really highlighted the danger that we have at the moment, that we forget about that core business of general practice, and things that were done for so many years suddenly get forgotten. So I think that's really highlighted what's been happening across the country in general practice, is that distraction. At the same time, though, I think it's been an awesome moment, and I think some clinics have done really well. And I think it's probably the first thing that isn't data, but I think is really important. It's actually showing clinics where some of their weakness and key dependencies lie on key people, rather than systems and processes and workflows that are resilient. Whenever there's a key person risk, yes, it gets in trouble when there's a pandemic, but also what happens when that person goes on long service leave, or when they go on leave, or when they leave the clinic. Things that are dependent on one person, on their knowledge, to me, scare me a lot. And that particularly can also be true in patient handover and patient care. So, if only your nurse knows that Betty comes in every 3rd week for this, what's the risk there if it's not well documented and not in the notes? So I'd say that's the first thing that we've been seeing the ball being dropped on, not by everyone, but just something to be aware of. As a clinic owner, I think you're really within your right, especially if you're, I know GP owners are probably a bit more across it, but for the non-GP owners, you're in the right to say, look, what's going on with our recalls and reminders? How many urgent recalls do we have? How many non-urgent recalls have we had? How long are they there? If you're a bit business focused, we like to look at our recalls in terms of like a debtors chart that you use for accounts receivable. How many do I have? And what's the aging on them? And that can really highlight the risk there for what's going on. So Sachin, I hope that's a good sort of first one to give some insight and something to be aware of. I'd say the next thing, and I know we're not going to talk a lot about vaccine, but actually chronic disease really comes into it. And a lot of clinics have stopped a lot of their chronic disease management program. And there's a reason those patients were enrolled in that chronic disease management program. It's because they're our most vulnerable patients and they need that care. And that's often slipped off. So at the same time as that sort of dropping off, we're also then seeing a corresponding drop in your doctor's billings. Because obviously, and this is more for a bulk billing clinic, obviously, than a mixed billing clinic, but any clinic that really does a lot of work in chronic disease management has seen quite a drop off in their chronic disease billings. And you know what? There hasn't been a corresponding drop off in the complexity of the work that's being done. And often it means that the work that's being done in a standard consult of 23 or a 36 hasn't had the preparation and the backing of a comprehensive chronic disease management plan to go along with it. So you're playing catch up in a standard consult for the work that used to be done as part of the chronic disease management plan. I don't know whether you're hearing that from any of the clinics that you work with.
Very much so. Keep going. I'll make commentary.
Yeah, no, it's good. I do know whether people get sick of the sound of my voice. You know, it's nice,
Never.
but it's not that nice. Yeah. Some of the awesome clinics we work with have also said, you know what, if someone was eligible for a vaccine under phase 1B and 2A for a clinical reason, so not for a demographic reason, they probably, there's a 99% correlation between that and who should be on a chronic disease management plan. That's really important to consider. And obviously also consider there might be some patients coming to your clinic that aren't your regular patients who got vaccinated, but as a whole, you can kind of make an assumption. You can say, look, someone has looked at this patient and said under phase 1A, as 1B or 2A, they were eligible for a COVID vaccine and they're not on a care plan. And I know everyone got a bit sick of computers telling us this person had an asthma 3 years ago and they should be on a care plan. You know what? This is a pretty awesome place to start. Someone's already done some work and worked out some eligibility. Now, as a clinic, how can we service that patient better? How can we provide better care for them by getting them involved in your chronic disease management in your clinic? So that's been a really good opportunity. And I know that sort of sounds strange, but a really good opportunity to leverage all the hard work you've done in your clinic to look at your chronic disease management. Speaking of chronic disease management, one of the biggest features we had, and we launched at our conference with you guys at SGPO earlier this year, was our MBS benchmark. And the number one page of benchmarking, so we benchmark your standard consults, we benchmark your different CDM item numbers, and then we benchmark your total percentage of CDM work versus your other consults. And you know what, that actually, because we're a data company, we love the data, that's become the number one benchmark page people visit. People want to see what they're billing in terms of CDM versus the national or the state average for each month. And then they want to look across, and this is, I guess, a takeaway for everyone, then look across each one of your doctors and see who are the outliers. So the outliers who are doing a lot, you probably just want to make sure all your systems and processes are in place. I know, Sachin, you did a talk a few years ago that I heard about making sure your CDM program was audit proof. So if someone is well above the parapet, probably something to make sure they're across. If someone's well down compared to everyone else in their clinic, you'd probably ask the question, why? Why in our clinic, if we're doing 10% CDM and this provider's on 2 or 3%, why? And there might be a reason. There might be someone who just likes to do skin work. There might be someone who has a different billing profile. We never know. But you know what? Some awesome conversations have happened when we said, oh, well, what about if we paired you with a nurse for the day and we showed you our CDM plan? And we showed you what an amazing resource we have in this clinic and how our nurses can help with your CDM billings. And that can be really powerful. And it's sort of not saying you're bad, it's saying, how can we help? And I think that's such an important way to frame a conversation. So that's been a really powerful sort of way to help get that CDM program back on track in between getting needles and arms.
Excellent. Thank you so much for that. So I'm hearing a few different threads there. The first one I heard is about the importance of solid systems. So your data really shines light on where there could be weakness. What you're saying is what you've seen here is, especially with that example you gave of a nurse that was diverted from their normal duties to vaccination, that their normal duties fell down.
Yeah.
So your data showed you that fell down, and thankfully they were able to, I'm assuming, use your your tool to actually...
They did. They became their favorite on their personal dashboard, and they wrote it really hard, and they got it. Yeah.
Perfect. But the importance of, key person, which can be comforting when you've got that key person, but the reality is that is a bit worrying, because if that person, for any reason, decided to, remove themselves from the environment, or, other things happen that are out of our control that remove that person from action, then the whole thing can fall down. And so systems is important.
Yeah, totally. And I think just systems too is important too, because sorry to interrupt, Sachin, but the pandemic has shown that we don't have to be afraid of tech. A lot of clinics didn't want to use, your AutoMed or your Hot Doc recall and reminder systems, because they were like, oh, tech, we don't want to use it. I think over the last 18 months, we've all worked out that tech is awesome, and tech done well can help you do things better. So to that clinic, I'd be like, the quickest way to remove key person is to use a computer. What computers do well? Repetitive tasks that require that sort of action. So sorry to interrupt, but I think that's a big one I learned this year.
Absolutely. And while you were talking, I wrote down the importance of dashboards and reporting, because if it was visible in the way you're describing, then perhaps that set of urgent recalls that went out of hand could have been course corrected way earlier. So in terms of dashboards, it's not so much about knowing the data. You need to take action. Like, you can look at the data all day, but you need to take action. So can you talk about perhaps how we move from, in your experience, from having the data, which is useful information, to action, which is where results and change happen?
Yeah. Look at that old thing, death by dashboard. I know Todd's called me about it a few times. For us, I think when we started this company, and I own the fact, we got really excited in showing awesome data, and that was also being part of a community that was asking for a lot of data points shown visually. For us now, it's become a very big goal, is not to show just data, but pair it with actions. So not to show, this is what your chronic disease percentage is. That's all great. They can make a dashboard that shows that, but pair it with a list of patients that are coming in today that are eligible for that care. Or, not to show that you have, $200,000 worth of debt, but pair it with some ways that you can get that debt down. So I think for me, it's all about pairing dashboards, and I love a dashboard. I'm a nerd, love a dashboard, with actionable insights. And that's been a big focus of our company for the last sort of 12 months. We've got about 460 clinics that we've been helping with the rollout of the vaccines. And it's been crunching data to do a nice dashboard at the top of the page, but below it, show each patient and what you can do for that patient. And I think that's really important in this space, is tying it back to the patient and the care you can provide. Because there's a reason we all get involved in this crazy business of general practice. It's so we can care for people. And so dashboards are good, but dashboards that give you insights to care for people are the best. So that's been a big part of that. And the other big thing we've found is that dashboards are good, but dashboards with a community around it are even better. So, we do webinars every second week with our practices, and we get over 100, sometimes 200 clinics that come along just to talk about what they can see in what we're showing in dashboards and how they can use it in their clinics. And that's an even better moment for me. That's when our data's making a difference. That's when your data's making a difference. And that's really important to us. What we've sort of got coming down the pipeline is that providing really distilled data sets just to your doctors and your nurses has become our #1 most requested feature. And we're just in beta testing of that moment. So each doctor in your clinic, each nurse, each provider is going to have on their mobile phone. And for those listening, rather than seeing, I've just picked up my mobile phone to make a point. We'll have access to the Cubiko data set just for them and their patients. And who's coming in today and what are the opportunities, but what do they bill? What was their CDM billing? How did they sit versus the national benchmark? And we're going to provide that data to them just on their individual level. And one of the really cool features is that we also have a button that, as the practice owner or the practice manager, can turn on or off, that shows you where that doctor or nurse or provider, allied health provider, sits versus the practice average. Because half the clinics I talk to say to me, Chris, I want my doctors to know where they're at versus the practice average. And half say to me, Chris, if my doctors ever knew where they were at with practice average, they'd walk away. So we're giving you the choice, because you know your doctors and your nurses and your workforce better than I could ever hope to know them. So we're letting you do that. And that's in beta testing at the moment. Really interesting things we've discovered out of that mobile first in that space is huge versus our normal data directory. People want to access their mobile phone to see what the data can show them. And the people want to look at their data in terms of how they can provide better care for their patients who are coming in today. So that's the two big things that we're focusing on. Empowering your individual doctors and nurses to make those care decisions, not being a blocker of the practice manager or the practice owner level in the middle.
Absolutely. Thank you. Probably a couple of comments I'd like to just make on that, which is it's really cool what you've shared and what's possible. I think the risk that we see when things fall down sometimes is without the right leadership skills and the right communication skills and the right cultural environment in a business, it can have unintended consequences because sometimes the message gets lost. So everything you've just described is what we find is in an owner's mind, that I want to help people do a better job. But sometimes the message gets conveyed in a way that is unintended, and the recipient receives it as, oh, they just care about money, or they just care about, or they don't care about me. But actually, when you speak to owners, they completely 100% care about their people, but they sometimes there's a lack of training and help around leadership and the skills that are required to then lead your people to victory. The other comment that I thought was interesting is how everyone is so interested in their own performance and like their own scoreboard. And we're not a competitive bunch at all as doctors, right?
No, never. Jeez, sorry, my nose just grew a little bit.
There's a real, I think, wish to know how you're doing compared to your peers, and so I think what you've just described exemplifies that. And people want a game they can win, and our job as owners is to make it easy for those people in our team to win by helping them bridge the gap between information and action.
And it's been really interesting to see the different cultures of clinics that want to embrace this. The clinics, you can sometimes see a bit of a correlation between team-based care and where there's sort of a focus on that, or are you renting a room for someone and that's it? I think it's whatever suits your business, and your business model is really important to you. But yeah, there's definitely some lead indicators there, to what will resonate.
Absolutely. And we've talked in one of our other podcasts about who is the customer, who's the client of your clinic. And that was really interesting. It's always an interesting debate. I think we settled firmly on, especially if you've got contractor doctors, they're your client, they're your chief customer. Yeah. And so you need to be servicing them in every way possible to allow them to go and do the good work with patients.
I mean, with the recruitment environment as it is in Australia right now, they are, as you've always said, it's much easier to keep them happy than to try and recruit a new provider into your clinic. But also I often think, yes, the doctor, the provider is your client, but you know what? They're the best one at keeping your other clients happy. I get to visit a lot of clinics and see their feedback, and often it's like, we hate it when we don't see the same doctor, or particularly with clinics with lots of registrars. Every year you give me a different doctor. It's the quickest way to make your other clients unhappy, is not to have that primary client there. So that's how I like to think about it myself.
Absolutely. I might see if Todd has some questions. He's never shy of a word.
Thank you, Sachin.
This is where I get nervous or excited. He's got that mischievous look on his face.
So I think, it's really interesting just listening to you talk about this, Chris, because there's really, this comes back to that Stephen Covey kind of quadrant stuff where, the vaccines have been really important and urgent, a very high priority that somebody else has determined for us. And so by definition, that drags work away from the important but not urgent quadrant, and a lot of that is improvement. So I think the price that will be paid for this is that we'll have dropped the ball on some general practice work, as you say, competing for resources. So nurses, admin, people getting dragged into the vaccine stuff, particularly if you're doing it a low volume and slow way, is a real problem. I suspect my thinking is that because hospitals have been kind of access blocked for quite a while, particularly in states with large numbers of community transmission. And unfortunately, that's coming to a state near you. It's easy to believe that it belongs to certain states and not others, but the roadmap is pretty clear that it's going to be all of us. That tells us that there's going to be a lot of hospital-based care that is either deferred or inaccessible. What impact do you think that will have on general practice in coming months?
So I think it's going to lead to a lot of urgent, important moments suddenly becoming practice-wide catastrophe moments. I think it's going to lead to a lot of very frustrated patients who get, find out that something was missed. Missed is probably the incorrect word. Who feel like something may have been missed along the way. I think we're going to be calling our medical defence organisations a lot. I think we need to make sure our near miss and adverse events register is in place in our clinic to cope with that. I think we need to have a really robust system in place around referrals. And I think the days of being able to say we're faxed off of a referral, our duty of care is done, probably will be behind us sometime soon. I know I can only speak for Queensland. Where I'm at in Queensland, they've got rid of paper referrals into the central referral hub. Now it's all electronic, so you do get that confirmation of that. And I also think that we'll probably see a lot more fractured care, which to me is one of the things I really strongly believe in, is that continuity of care is so important. But people will look for a doctor or a clinic that can provide them rapid access to what they think they need straight away, which will suddenly lead to fracturing of care. We've seen it a lot with some of our most complex patients. They'll book into any clinic they can get an appointment with that day for their urgent, important issue, but actually that will complicate their care overall and make it probably a bit of a worse clinical outcome for them. So I think we're going to be playing catch up. I think that it's probably the last thing we need, but it's going to be incredibly stressful.
Yeah, I suspect that's true. The really frustrating thing is most owners and clinicians, admin, everybody in the practice feeling pretty knackered at the moment. But we're just about to hit the wall in the marathon. I think there's a fair way to go, and there's a bit of pain to go through. It's really not the time for a pause. There were two more things I was just going to cover off on. One was whenever we hear dashboards, we should also think role clarity and accountability, because it's really what you're talking about is, you're going to get some data, but data without ownership and responsibility and accountability is kind of just, it's like a story, which is nice, but you've got to do something about it. And then you need role clarity around who's responsible for what. So I think that that sort of more data vignettes that you're talking about that are role specific is really cool. I'm going to politicize the last thing here, which dovetails into what you talked about earlier, Chris. General practice receives around about 7% of their health budget. The hospitals are sucking up an enormous amount of money from federal government and state government, and so there is really going to be a lot less money for general practice. That's the reality. And one of the things that you talked about, the CDM nurses being quiet. The problem with that is that there was a deliberate change in policy whereby the federal government deliberately shafted clinics by removing access to the item numbers for telephones, and they are accountable for the loss of CDM care, for chronic disease care for these patients with that, and we should not let them off the hook. We need to make sure that they pay for that, because that is only about screwing patients and looking after purse strings at a time when hospitals are no longer able to do that. So I do think it's really important that we sheet home responsibility for this stuff, because there will be a lot of nurses literally sitting and twiddling their thumbs in practices where they've deemed it unsafe to have face-to-face consultations at the moment. And I ordinarily wouldn't want to politicize stuff, but hey, once I get a bit frustrated.
And I could put it in a plug for a data company that when you need to make a point, what they often listen to is a hard number. Like if you say this has happened and X percent, it does with all the email that they get and all the noise they get, a number can be very powerful. And I think that's something in general practice will probably be a bit lacking in the last few years, is actually having the numbers to show the value that we provide, but also the impact that decisions have on our businesses. We need to get better at telling that story and making noise with solid data, not just feelings.
Absolutely. And communities. Absolutely. All right. I'm really grateful for your time,
Thank you.
Sachin, as always. And Chris, thank you for your wisdom, commentary, and a bit of a rant at the end, just for something different. I'd like to wind up and thank everybody for their time. You can get more information about Chris in the show notes, of course, as always. And we look forward to our next conversation. Chris, go well and enjoy the rest of your day.
Thanks, mate.
Thanks, Chris.
Thanks for tuning into the Scale My Clinic podcast with Todd and Sachin and the team. For more information and to get the resources mentioned in this podcast, visit www.scalemyclinic.com.